So just waiting for the slides to load. So I've taken the liberty to slightly deviate from the topic to speak on AI and radiomics. I think first of all, we must be very comfortable with these terms actually to understand what actually we are talking about. And then the major portion of my talk is like 60–70% is basically the basic concepts of what artificial intelligence and radiomics is, and probably 2 or 3 studies which will actually explain you how it is being used in clinics. And the other aspect is whenever we talk about artificial intelligence or radiomics approaches, there are 2 aspects of it. One is a process driven thing where we are using these technologies to make our processes more automated. And the other is a model development, predictive and prognostic modeling. So my main focus is basically towards the predictive and prognostic modeling in this particular talk, because I don't think in 15 minutes we can cover each and every aspect of it. So this is our AI lab, where we are working. We have 4 GPU-based computers on which we do all sort of calculations, and these are behind the scene codes, Python codes, which we use for our AI and predictive modeling. So the very basic question: how do we actually make a research question for any sort of an AI based or a radiomic based approach? Conventional teaching is we formulate a hypothesis and then we do a data collection and then we analyze and interpret it, and then probably we get some sort of a new candidate biomarker, and then we do a technical and clinical validation of it. But it has its own limitations, because when we are talking about clinical data as well as the imaging data, we are having a huge amount of data which we can generate from these medical images. And to follow this conventional approach is not the right approach in this particular scenario, because we can't actually do all kind of statistical analysis in these scenarios. So what we do is basically we do a data collection and then we do a technical validation, and we try to find it's an exploratory phase. We have images of maybe 200 patients, and then we try to get as many features from these particular images, and then we try to find out something which is very interesting, and then we analyze and interpret it, and then we formulate a hypothesis on some particular potential candidate biomarkers, and then we actually do a clinical validation in this particular scenario. And this is basically the right way of approaching AI based approaches for our clinical research. So what exactly is radiomics? Radiomics is basically an extraction of mathematically and statistically derived features from the medical images, which represents the distribution of pixels and voxels and their interrelationship with a no a priori hypothesis, which is very important. We don't have any hypothesis prior to extracting these features. And then probably once we have these features, then we try to correlate it with our clinical outcome. The another aspect is radiogenomics. I don't think we can cover that in this particular talk. So the overall process is we collect the data. Data here we are talking about the images as well as the clinical data, and then we do some sort of feature extraction with the help of some softwares. What we are using is CERR, Computational Environment for Radiation Research, and PyRadiomics, and then we have multitude of features which we can extract from these images. Then we do a feature selection, because not all features are important to us. There are special methods for those particular things. And then there is a discovery phase where we apply machine learning and deep learning approaches to make some sense of this particular data which we have generated from these medical images. And then we do a validation, preferably internal as well as external validation, which is very important when we are developing these models. And the AI and machine learning and or deep learning things can be utilized in this whole process, which can make this process smooth. So the challenges is everything is fine when we are talking about radiomics. No, there are some imaging acquisition issues. The different parameters in the imaging acquisition issues can cause many problems. Image quality is an issue. Image labeling, because we have a lot of data. I was talking to Dr. Sridhar. Actually, we have so many images with us, but again, the problem is it is not a labeled data. It is not a processed data. And the segmentation issues are there, because multiple segmentations can give you a multiple sort of a radiomics feature which are not in conjunction with each other. And then when we have a limited data, then there's issues of data augmentation which we should use or not use. Again, that is an issue. So data curation and data pre-processing is the most challenging and the major deterrent for any radiomics project. Otherwise, it looks very fancy. You can do so many things. But the major problem is with data curation and data pre-processing, and which takes 90% of your research time. 10% is only the model building. It will hardly take a couple of months to build a model. But the major problem is data curation and data pre-processing. Fortunately, we have some imaging biomarker standardization initiative where they have defined what should be your radiomics feature and how you should collect those radiomic features, what should be the property. And they have some family of features which they have defined in total. And I will very briefly discuss, because I can't discuss everything here. And what they have done is, where there are multiple institutions where they were actually collecting these features, and then there was a survey, and then they defined that these are the standard thing which you should do while you are collecting your radiomics feature from the images. What we are using is primarily we are using Radiomics and Sbrt here, and these are all I have highlighted in red. These are all the software which are freely available. They are not a paid software; they are freely available. So the shape, we all know that how compactly the pixels are being distributed over a tumor area. That is what the shape features tell us. And then we have a textural features which are very important. The basic philosophy behind this is basically they represent some sort of a biological process. For example, I'll just give you a very simple example. This is a gray level concurrence matrix. So we are seeing an I and J matrix, and this number which you can see here, this is basically an image with a gray levels, and this is a matrix where we are collecting a data. So I is 1 gray level and 1. So pair of 1 and 1 we will see in a one particular direction, and then we see that it occurs on 0 times. Then there is a pair of 2 and 2 which we can see here that it occurs 1. So this way we collect the data, and then we fill out these matrices, and then we go on other direction, we change the direction, and again we collect the data, and then we fill up this matrix, and then we do some sort of a statistical analysis on these and collect the features. This is the basic methodology. Same way, this is a gray level run length matrix. So I is basically, J is the gray, I is the gray level and J is the run length. So run length of 1, we have 4. 2 run length of 2, we have 1. So same way we actually go in X and Y direction, and then probably we get the matrix and we collect these data. And these are the textural level radiomics features which we collect in our patients. So finally, we have this all features, large number of features. The problem is the curse of dimensionality here, because we have so many features, because in one particular patient, we can get approximately 200 to 300 features. And then we have 100 or 200 patients. So this is basically becomes a curse of dimensionality. You have a wide table, which is very difficult to do a standard statistical analysis in these patients. So we do need to select these features, which are the good features, which like, for example, we have to test and reset. We have a rider data set where those authors have done a CT scan of a patient, and then they have waited 15 minutes, their coffee break, and then again repeated a CT scan, and then collected again the features. And if those two group of set of features, if they are coinciding with each other, then they are good features. Otherwise, if there is some change in those features, we don't need those features. So they are not reproducible. Similarly, there is segmentation, inter and intra-observer segmentation issues. If with two segmentation structures, we have a different features, and again, we avoid those features. So there are methods to select these features, and we select the most stable and reproducible features, remove highly correlated features, and then we get the true radiomics feature, which actually we can work on that. Finally, we do a model building, and we can have a very beautiful models with us. But the problem is, again, as I was telling you, that majority of the studies which we can see, the radiomics based approaches, they actually don't have a basic thing which every predictive modeling should do. They should have a training, test, and hold out set data. And majority of these studies, they don't have this sort of study. And this is a very good systematic review here. Actually, we can see only 10 to 20% conformity was there, where they were actually following all sort of methodologies which should be done in this predictive and prognostic modeling. So very briefly touching upon the artificial intelligence and radiomics part. So this was the radiomics, where we collect a lot of data and then we utilize these deep learning approaches to make sense of this particular data. And first of all, we must understand what is not an artificial intelligence when we are talking about artificial intelligence. So anything which is explicitly programmed, like we have a data and then we define some sort of a rules and then we get an answer. This is not an AI. This is basically a automation. You have a data, you have defined some rule, and then you are getting some answers. And this is basically a explicit programming. The AI and machine learning, in a very crude way, in a very higher level overview of AI, is basically you have a data, you provide answer to an algorithm, and then the algorithm figures out what are the rules, how we are getting these answers. And then when you give them the new data, then probably on the basis of the old data, it try to give you an answer. So it is learning from the old data. So you are giving a data and answer to the algorithm, and it gives you the rules. So a very cartoon overview of what is an artificial intelligence. This is an artificial neural network where we have extracted, we are presuming that we have extracted all the features from our images. These are the 5 features we have selected. And then all the features are being subjected to all these nodes. These are known as neuronal nodes. So they are nothing. They are the mathematical formulations where we actually put all these features into this algorithm, and from one particular mathematical node, it goes to other nodes, and this goes on. And finally, we get a probability that this lesion will be a malignant or a benign. So what our question is, what is our outcome of this particular lesion? Whether we want to predict that this lesion is malignant or benign. So as it has predicted that this malignant has an 80% probability of benign, but we know, because as I have told you, algorithm knows the answer. It knows that this is not a benign, this is a malignant. It goes back and repropagate, and then try to find out, adjust the weights of these nodes, and accordingly change the nodes, and then again come back. And this is a repetitive procedure until it gets a better answer, or a better probability of what actually the answer is. And this is how the whole neural network works. This is a very basic concept how this neural network works. What is the difference between machine learning and deep learning? We always use these terms interchangeably. So machine learning is where we are extracting features manually, as we are doing in radiomics process. We are extracting features manually and then putting these features into an artificial neural network or any form of algorithm, deep learning, machine learning algorithm. And in deep learning, what we do is this is all automated. We don't have to manually extract the features. These are being extracted by the algorithm by itself. The drawback of this is basically it is a black box kind of a thing. We don't know what actually it is doing. Actually, we just subject the image to the deep learning algorithm. It extracts the features and it goes into the machine. So this is very briefly, I will this is a paper from University of Pennsylvania, Philadelphia, where they have extracted radiomic features and then they have tried to correlate it with the outcome. I know it's only 2 minutes, I'm just trying to finish it off. So what they found was actually they could actually divide these patients into a high risk and a low risk patients, and it was correlating with the radiomics features. And this is one study, and the very interesting study is this. I would like to just focus a few emphasis on this particular study. So we all know UNet, where we do automatic segmentation. These are algorithms which are being used for segmentation purposes. The authors very cleverly tried to find out these are the features. What they do is they convolute the features from an image and then they regenerate the contours. So in this particular area, they have so many features, which is like 55,000 features, and from the CT, and 55,000 features from the PET. And with these features, rather than trying to do a tumor segmentation, they actually try to do a model building. They try to build a model to get a sense of what actually is happening. And it was basically put into a survival classifier. And there was a difference in survival. The very interesting is, if you look at this image, which is like the pre-treatment images, at a different slices level. This was the primary tumor here, and there was something here, but it was not found to be significant. And once this patient recurred, but the AI algorithm could identify this area, which is highlighted here. So they backpropagated the weights on the basis of which it predicted that there will be a recurrence. And it could actually identify prior to the treatment that there are some areas in the scan which are high risk, and actually the recurrences were happening in those areas. So this is again a very interesting study, and this is a newer approach, which is a dosiomic rather than radiomic. It was a dosiomic, where actually they subjected the dose profile of that particular patients and extracted feature from there, and they tried to predict the radiation pneumonitis part. So, and this is what we have been doing. We have many publications with regard to deep learning and AI. We have been publishing these features, though we haven't done anything regarding the Sbrt part, but we are doing for esophagus. This is basically a quantitative imaging, artificial intelligence, radiomics combined clinical data. We have a collaboration with an Australian institute and Keele's University from UK. And we have already, this is being registered in clinicaltrials.gov. This is basically the last two slides. The patients who achieve pathological CR after concurrent chemoradiotherapy, they fare better. So can we predict the probability of achieving pathological CR based on pre-CCRT imaging characteristic? And then probably we try to do the radiomics approach as well as a deep learning approach, and we were trying to compare those results. And a very preliminary results which we published in ISTRO also. So here actually this is, you can see that we have a tumor area which is being segmented. This was automatic cropping was done by a software, and then this was the tumor which was being subjected to AI algorithm. And interestingly, we could have a very good model which can predict the pathological CR. But very interesting was when we back projected the weights onto this particular image, what was the criteria, how the AI algorithm was predicting. So it was actually not doing some sort of a rough thing. The whole weights were concentrated on the esophagus as well as a periesophageal area, and which actually gave us a confidence, actually we are going in a right direction. So this was again a very novel approach where we try to predict the suitability for DIBH using an AI algorithm, and we just subjected the X-ray images to an algorithm, and again we back projected the weight which could define the suitability for DIBH, and it was actually addressing the adequate area. It was not going in any area and defining that whether patient will be suitable for DIBH or not. It has a training accuracy of 93% and validation accuracy of 80%. So it always seems impossible until it's done. And I would like to block your dates for our national conference. We have a dedicated session on half-day session on artificial intelligence, and we will be discussing many aspects of it. Mainly the major focus would be how to go from theory to clinics. That is the main emphasis of this particular conference. Thank you. Thank you, sir.
Thank you, Dr. Kundan. It was very complicated to begin with, as artificial intelligence is always there.
It's very difficult to explain everything in 15 minutes.
But I think we made it very easy to at least understand. So thank you very much. I think we are running quite late. So maybe one question, if anybody has got, then we can ask.
Yeah, Anil. No, we haven't done anything. But again, there is a study where what they have done a very interesting thing in terms of Sbrt. So in CBCT, they were trying to predict an ITV. And when they projected that ITV to what actually we do on MIP images, and then we generate ITV, and there was a dice similarity of more than 86. So which is very interesting actually. You don't need to do a 4D CT scans and draw the tumors. You can actually do it on a CBCT itself. That is what they showed. So I haven't shown because of paucity of time. So yeah.
Thank you. Thank you, Dr. Kundan. I think we'll go ahead with these special lectures.